I became interested in understanding the relationship between patient safety climate and standard precautions for a number of different reasons. First and foremost, because far too many patients suffer a preventable adverse event or healthcare associated infection every year. Secondly, healthcare workers do the best they can every day. But sometimes that best isn't all that it could be or all that it should be. And so we need to better understand factors that help healthcare workers do the right thing, the right way, the right time, every time. The research that we conducted involved the development and testing of two tools, one of which was an observational tool where we observed healthcare workers' behaviors and adherence to standard precautions. The second was a survey tool where we asked for healthcare workers' perceptions on the features of the safety climate, such as teamwork, communication between different people on the unit, teamwork across different units, whether their unit had features of a non-punitive work environment, and so forth. The second component to that same study was to examine if features of a better safety climate, meaning if you felt more positively about your safety climate, if those were related at all to higher levels of standard precaution adherence on those same units. So the way we conducted the study, and I'm going to speak here specifically about the observations, was that we involved and we recruited a number of hospital site liaisons. And those liaisons could be nurses, they could be nurse educators, infection preventionists, or hospital epidemiologists. What was so neat about that piece of the study was that I really was able to take very, very busy professionals who do very important work every day in training nurses and others, and sort of stop them in their tracks and say, hey, take a minute and look at what's happening and watch what's happening and start recording this interaction between healthcare worker and patient. And in so doing, they were able to really increase their awareness of what was happening by observing these specific dynamic interactions. So the findings of this study, and this is the largest known observational study of its kind, where we recorded 1,700 plus observations, and we surveyed over 140 nurses, really confirmed part of what we already knew, in that we know that we have substandard adherence to components of standard precautions such as hand hygiene. What we added to this was we were also able to quantify components of adherence to personal protective equipment such as glove use, use of sharps equipment, and placement of linens and dirty and contaminated linens. And what that showed us was really interesting, in that many times when healthcare workers did not perform hand hygiene, they happened to have gloves on even when they weren't indicated. Conversely, when gloves were indicated, they didn't use them. And so they weren't protecting themselves, nor were they preventing the transmission of infection to others. And so this was really striking in trying to understand what the decision-making processes were for that particular individual. So we're really excited to share that because of this pilot study, which was successfully implemented in very large part because of the caliber of the study site liaisons, we were able to apply for and receive some CDC NIOSH funding to expand this nationally. So we're in the process of doing that, but we're going to add into this both healthcare worker and patient outcomes so we can examine that entire relationship. These tools can be used now, so they're able to be adopted in the healthcare worker setting, so they can quantify this full spectrum, this complement of behaviors, because it's not one practice, hand hygiene, in isolation from whether you follow the Cowdy bundle or the CLABSI bundle, etc. If these basic behaviors, which form the basis of all the healthcare worker prevention behaviors, are followed, then the rest should follow suit.